My name is Janelle Palacios, and I will be sharing the presentation Reconciling the Past to Nourish the Present and Strengthen the Future. I shared this presentation on September 15th in 2023 in Phoenix, Arizona at the 2023 AIM Collaborative Conference. I have no disclosures to share, no conflicts of interest. And when I first started this presentation, I shared a story about the power of listening. I'm a nurse midwife and I work in a very busy hospital center in Northern California. I teach OBGYN residents. And one night, it was very, very busy. We had a bustling evening, and triage was filling up, as well as I believe every labor and delivery room was filled, and even postpartum was filled. And we received a phone call from the triage nurse telling us that there was a frequent flyer in triage waiting to be seen. Now, the nurse's report was in such a way that let us know that she was annoyed with having this patient. She'd seen this patient a few times before. She believed that the patient came with vague symptoms, and a quick assessment by one of the providers would allow us to quickly turn over the room and allow another patient to come in who needed to be seen. I quickly glanced at this patient's chart and noticed that she was a bit complicated and so outside of my practice. But I asked one of the residents if they could go see her instead. And I took the resident's phone. Now, this is the big thing, taking away a communication device so that this resident would have undisturbed time with this patient. I told the resident, I'll give you 30 minutes. I won't interrupt you. No one's going to call you. I'll take your calls. Please go find out what's going on. She's been here quite a few times this past week and last week. I want to know why she keeps coming. So let's find out. The resident returned about 45 minutes later, and the resident was in tears. And she recounted a story about how this patient had been coming every night to check on her little one, almost every night to check on her little one. This patient was preterm, had a number of complex chronic conditions, and was also bringing her young child who had severe disability and was, in the nurse's words, was bouncing off the walls in the triage room. Now, it's like midnight to 2 in the morning when this is happening. So there were questions as to why this person is bringing this child. Why is this child not asleep? What's going on? And it turns out that the patient's partner works two jobs. And this is the only time in between two jobs during the day job and the graveyard shift that he could drop his partner, his wife, off at the hospital. She had received vouchers, transportation vouchers, to try and use the bus, the public transportation system, to come and do a prenatal appointment with a maternal fetal medicine provider, so a specialist. But due to the complications of her child's schooling, where they lived, the amount of time it would take to go back and forth, she didn't feel like she could use the voucher effectively, as well as having to care for this high needs child on a bus ride where there were a number of stops and probably over an hour and a half of being on a bus. So this is why she was coming in with her partner. He did not get off work until around 6 in the morning. And so she needed a place to kind of hang out until he returned. So she was doing her prenatal care in triage at midnight in the hospital. It turns out that this patient was right, something was going on, and her vague complaints and concerns really did create a picture after a really thorough physical examination and some studies that she had some big issues. Unfortunately, our system failed her because she had to make a really difficult decision. The recommendation from our team is that she stay in the hospital and be observed. It was not within her ability to drop her child off or have someone take care of her child. Her partner was busy working to make sure that they had rent and food. No one in her community or her family did she feel she could trust with her high needs child. And so the only recommendation and the only solution we had for her is that we could give her a taxi voucher to go to a nearby hospital and drop her child off at the children's hospital, leave him, and then return and be admitted. This is the power of listening. It is really important that we sit down and take time to listen to people's stories. Automatically, we have our own biases. We see a patient, we see their chart, we automatically have assumptions already brewing, anticipating what the problems are going to be. In this case, it took a thorough assessment and sitting down and talking to this person to really understand what was going on, and then find out there were big problems. And then again, in listening to her story, we knew that she was not abandoning her older child, but the system would not look at it that way. So we made sure that our social worker and our providers wrote really detailed notes in our charting to indicate that this was really the recommendation and the best thing that we could offer her because simply our system did not meet her needs. I'm hoping that today, through the power of listening, we will be able to overcome some implicit bias that people may have about American Indian Alaska Native population. I'm going to be specifically talking about Native American maternal child outcomes. I'm going to talk about a little bit of history in terms of understanding theory and understanding health outcomes. To concrete us in this work, I'm going to give 4 generations of my family as examples. I'm going to talk about American Indian history in general among the lower 48, the states. I really do not talk a lot about Alaska Native history. That is a very important history that is missing. But for this presentation, I'll keep it to the lower 48. And with the understanding of history and theory for maternal child outcomes, I'm hoping that we can reframe Native American maternal child outcomes, recenter and restore and heal what we can to improve these outcomes. So again, just a few learning objectives. We had a wonderful little vignette of the power of listening. So this slide might be very familiar. A number of people have seen this data. This largely says that in our country, a developed nation, that Black and Indigenous women die 2.5 to 5 times the rate of white women. Education is not protective for Black women. And as Black and Indigenous women age, their maternal mortality and morbidity increases at a sharper rate than white women. If we look at sudden unexpected infant death by race and ethnicity, we can see that there are also large disparities in outcomes. American Indian Alaska Native infants swap places with Black infants for first place in terms of who dies more frequently during SIDS or SUIDs. Between 2016 to 2020, the SUID data, the sudden unexpected infant death data, showed that Arizona was just slightly below the US average of about 90 infant deaths per 100,000 live births. Again, it really depends on which reference years you use, because Arizona will also be on the higher end of the national average. I just want to give a shout out to this really wonderful report done by the Arizona Department of Health Services. It's the maternal mortalities and severe maternal morbidity in Arizona. I'm going to borrow a few of their images from this report. You can see on the side there are QR codes for a lot of this information. So in Arizona, when we look at all deaths related to pregnancy, that happen in the perinatal time period, about 16.4% of those deaths are happening around at the time of being pregnant. About a third of them happen within 42 days of death having been pregnant. And then if we look at from pregnancy, from day 43 of pregnancy to 365 days of death, about 50% of deaths amongst the birthing people or women happen. And if you look at these numbers, 76 to 91% of these deaths are preventable. There are differences when we look at race. Race in this case is not meant to mean biological differences, okay? Race in this sense is actually related to the constructs of social interactions like racism that can impact people's health. So American Indian or Alaska Natives, although they make up about 3.9% of delivery in the hospital, they make up about 9.8% of severe maternal morbidities. So we have small population numbers, but about 10% of their population make up these pregnancy-associated deaths or percent of severe maternal morbidities in the state of Arizona. This next slide also just shows that if you were to predict roughly the pregnancy-associated mortality ratio of American Indian Alaska Native, about 128 deaths per 100,000 live births will happen. And this by far is the highest expected rate if you look at the different races included here. This information is also based on smaller numbers. So the true numbers are a little bit difficult to really identify. And it's expected that of these deaths, that about 100% of them would be preventable amongst American Indian Alaska Natives. So if we look at the rate of severe morbidity morbidity by maternal race and ethnicity, again, about 303 American Indians, Alaska Natives experience this occurrence per 10,000 deliveries in a hospital. So this is just to show you as another indication by insurance pay type Indian Health Service, almost 340 cases of severe maternal morbidity by insurance will happen amongst American Indian Alaska Native people. We know that American Indian Alaska Native people have high rates of diabetes and hypertension spectrum disorder. So again, this is just to show you that if you have comorbidities, that pregnant people or the rate of perinatal death or severe maternal morbidity is going to be a little bit higher. Well, not necessarily a little bit, about 3 times higher. That's a good amount higher. I thought this slide was also very important. So if we're looking at county, you can see that the most rural counties have very high rates of severe maternal morbidity within Arizona. And when we think about county, like the rural counties in figure 49, there are 155, almost 156 cases per 10,000 deliveries of severe maternal morbidity, just if you lived in a rural area, which are listed. And we know that a lot of Native Americans in Arizona, American Indians, live in rural areas. And we also know that people go back and forth. So people may come to an urban area like Phoenix or Tucson and then return to their communities. So one of the big things, if we're looking at access to maternal health across the board, American Indians they live in predominantly maternity care deserts. These are areas throughout our country where there are very few obstetricians, family practice doctors that practice OBGYN or midwives and doulas. So these are specialists in the birth world. In rural areas, they are lacking these specialists and lacking high level care. The drive times can really vary depending upon which state, which region you live in. The drive times, right, can range from 20 minutes or 15 miles to more than 60 minutes or 120 miles. So it does vary within our country. We're a pretty large country, a lot of rural communities still. People birthing in these communities have just the access of geography to getting care. Among American Indians, there is a high rate of late to prenatal care, and there are a number of reasons for this, as well as they have high rates of inadequate prenatal care. In some of the literature, Native people have the highest rates of all races that have late to prenatal care or higher rates of inadequate prenatal care, so not the recommended ACOG number of prenatal visits. And reasons for this include access to insurance, right? So possibly one would be first identifying timing, the timing of diagnosis of a pregnancy, and then access to insurance to access care. There are also well-documented instances of mistrust in healthcare. So CPS being involved whenever people come to prenatal care, if someone screens positive for something, state, local, county officials law enforcement can get involved, and that can really impair the trust that people have in the medical system, as well as mistreatment, just frank, right out mistreatment and obstetrical violence. There's a lack of consistent, linguistically and culturally sensitive providers. This is one of the barriers for Indian Health Service in particular. There have been a number of government accountability reports that document there is a high need for providers in general to come to Indian Health Service. But when they are there, it's ideal that these people are reflective of the community that they're serving or have special training in cultural sensitive care. And another area that impacts access to care, prenatal care, postpartum care, even delivery, would be social determinants of health. For if you live in a rural community and you do not have a running car or a full tank of gas, or you have prioritization of other family members who might have higher needs than your own to use the resources or time or money that it takes to go to prenatal care, there is going to be this um, shift in attention and resources. So there are a number of social determinants of health that can really impact access to care. This is my version of trying to help people understand. If we're looking at the tree of life, and this is borrowed from Vanderbilt's beautiful similar image, and I've just made this really according to American Indian Alaska Native people, that if the leaves are supposed to be the outcomes, we don't necessarily see a flourishing tree right here with beautiful leaves bearing fruit and flowers. We can kind of see a barren tree where on the infant child side, we have high rates of SUIDs and SIDS, preterm birth, low birth weight, birth with children, deaths, unintentional injuries and death, infections, homicide. On the maternal side, we see things like obesity, diabetes, hypertension, violence, substance use disorder, mental health, suicide, homicide, unintentional injuries. And if we're really trying to understand these outcomes, I think it's really important that we pay attention to what's going on with the roots. And these are things like violence and homelessness, incarceration, the social determinants of health. So we're going to talk about life course, weathering, adverse life experiences, and historical trauma, because the intersection of all of these theories helps us really understand the trajectory of American Indian maternal health outcomes intergenerationally. So this slide explains life course theory as it pertains to racial and ethnic differences. In general, from birth to death, we're looking at what happens from birth to death over a person's lifetime. White women may experience less assaults over their lifetime, while Black and certainly Indigenous women are at risk of experiencing more assaults over their life course, with fewer protective factors to mitigate the assaults, overall affecting reproductive and perinatal health. But we can extend this thinking to also include men as well. Because of their lot in life, there will be different protective and risk factors that they encounter that are societally shaped. A lot of the life coursework has largely focused on Black-white differences, not so much on American Indian Alaska Native differences. I really want us to zoom in on this period of from birth to death. Okay. We know, this should be very familiar with you, that in childhood, we know that the presence of traumatic childhood experiences, such as abuse, neglect, and witnessing experiences like crime, parental conflict, mental illness, substance use, imprisonment, they can result in long-term negative effects on learning, behavior, and health. As the number of adverse childhood experiences increase, so does the risk of negative health outcomes throughout someone's lives. So we look at these ACE scores, adverse childhood experiences scores, from 0 to 18. The ACE survey should be given to people who are 18 and older because it is a reflection of their childhood. And the ACE survey does not assign a value other than 1 for having experienced something, and then the total score can be 0 to 10. But the ACE survey does not assign like a level of difficulty. That is missing from this. And as well as does not measure resiliency, which we know is very important whenever you have adverse child experiences. So this is just another example of the ACE, adverse childhood experiences, how, again, here's the tree of life roots, and you can have these social determinants of health like violence and poor housing quality or homelessness, discrimination, racism, poverty that can impact the roots in the tree, which can really lead to divorce, mental illness, chronic health problems, chronic pain, substance use. So additionally, these traumatic events create dangerous levels of stress that can affect healthy brain development and in turn affect how the body responds to stress. Adults with adverse childhood experiences have an increased risk for smoking, alcoholism, depression, heart disease, suicide attempts, and diabetes, as well as other illnesses and unhealthy behaviors throughout one's life. So when we take into account the entire lifespan of someone's life and we understand the interaction between risk and protective factors and subsequent health outcomes, we begin to understand how assaults over a lifetime can compound or accumulate. This next slide just demonstrates if you were to be given an adverse childhood experiences survey, a score of between 1 to 3 is usually related to intermediate risk for toxic stress. Score of 4 or higher, there is a higher risk for toxic stress where you're 2 times more likely to be smoking or 2 times the risk of using alcohol, and it can increase the risk of suicide by 1,200%. Scores of 5 or higher more likely are related to experience violence, more than one marriage, broken bones, depression, using prescription drugs, and autoimmune diseases. And if someone has a score of 6 or higher, now remember 10 is the ceiling, 6 or higher, their lifespan can be shortened by 20 years. There was a study that was done, published in 2018, where they looked at ACE scores, adverse childhood experience scores of 4 or higher among different populations. Almost a third American Indian Alaska Native people reported an ACE score of 4 or higher. And this was by far the most, the highest rate of ACE scores per population. So I want you to think about from birth to death and think about these adverse childhood experiences and protective and risk factors over life that can support your health or be a detrimental, have a detrimental impact on someone's health. One person, Arlene Geronimus, called this weathering. When we take into account the entire lifespan of someone's life, and we understand the interaction between risk and protective and subsequent health outcomes, we can understand how assaults over a lifetime compound and accumulate and can weather someone, can accelerate someone's health and wellness, accelerating this deterioration of their health over time. Additionally, this concept weathering was largely studied among Black women in terms of their maternal and child outcomes. At first, it was looking at low birth weight amongst different age Black women, and there was a narrow period of time before age 25, so about 18 to 25 years of age amongst Black women, that they tend to have better outcomes, maternal child outcomes, than they do when they're older than age 25, which is just astounding. So as they age, because they're exposed, the theory goes because they're exposed to daily toxic stress and face barriers of social determinants of health at a far higher rate than other people, it can accelerate their aging. It can accelerate increased risk of hypertension, diabetes, obesity, different things that really impact their health. So I believe weathering is relevant for Native American women too. So what about the parents and grandparents' life experiences, this area in the yellow? How could their health impact present conditions? And does it matter? The answer is yes, it does. So about 20 years ago, I tried to help providers and researchers understand this nexus of a life course theory, weathering from birth to death, differential experiences throughout life presently, and then also what happened to your parents, grandparents, and their grandparents has an impact on how you show up today. And research has shown that this impact is very relevant today. So when we look at this, this is my attempt. When Word 2001 was out and you could only make squares, straight lines, and circles, I created this in a manuscript article on how to understand Native American women's health and outcomes, looking at traumatic events over their lifetime, intergenerationally, traumatic events that have happened on their people, their community, their tribe, and how this has compounded cumulatively affecting intergenerational outcomes. So, how do we bring all this information and kind of apply it to a family, people, maternal outcomes? So, oftentimes when we think about um, cases, this is what we often see. We see, usually black and white on paper or on the hospital chart now, electronic hospital charting, where you have the person's name, age, maybe ethnicity, and then their gestation, their gravida and parity information, as well as like any significant problems they might have or the experiences of their daily lives. So if we were to look at these cases and just to try to understand maybe an assigned ACE score or their history up until age 19 or 40, that we can see that their lives are a lot more complex than what is presented through just history of interpersonal violence, chronic hypertension, gestational diabetes, um, smoking. If you were to turn these cards over, these are the people who we see. So these four women are women I know, my great grandmother on the far left, my grandmother, my mother, and myself. So three of these women were teen mothers. Combined, these women survived over 10 preterm pregnancies, 2 infant deaths, a coerced sterilization, suicide ideation, alcoholism, abusive violent relationships, poverty, and daily encounters steeped in racism. This presentation will discuss each of these women's experiences of maternal infant morbidity and mortality in terms of their life context, not their race, but their inherited histories, their launch in life, and the opportunities open to them in the life they lived. Their stories will help frame understanding of how powerful the background story really is. So I'm going to start with history, a marginalized history, one that is not often recognized or discussed. Again, what's going on with that soil? So let's find out. I would like to suggest that we have an unreconciled history, that very few in our nation are aware of what has happened amongst American Indians, Alaska Natives. We all know the story of when first contact happened with Columbus. We then know the story as the 13 colonies were created and how important Native people were. So we know those stories vaguely, a little bit, but we don't know the really important ones that have big impact on health today. So this is just a preview of some key historical events. This is not the entirety of them. There are far more than this. This is not a complete list, but this is just a few that I will share with you. And I want to also share that while there are there are over 576 tribes that are federally recognized in our nation today, that there are more tribes than that are federally recognized. And each of our tribes have different cultural practices and sometimes languages. So we're very diverse. But I'm going to again keep this presentation locked on the lower 48 states. So we seem to forget that in 1491, the Native population was 100% Native. History is recorded from conquerors' lens. Typically, only their versions are widely known. So narrative holds power. That Columbus discovered America is still a pedagogical falsehood, but upholds the narrative to unsettle indigenous claims to this land. It's uncomfortable. When we look at state and national data, findings from the American Indian population is really challenging. We don't know where they are. We are few in number, and therefore our data is not statistically significant. Well, there are a few historical events and policies that have greatly impacted our population. So today, a lack of understanding and dismissiveness to finding our data has led to another type of genocide, data genocide. This report graded each state on their ability to count American Indian, Alaska Native COVID data, and our nation failed as a whole. In essence, the American Indian, Alaska Native population is the asterisk nation. We are not statistically significant, and there are big reasons for this. The doctrine of discovery is actually a set of papal decrees or papal bulls. The first was in 1455 with Pope Nicholas granting the Portuguese monopoly trade with Africa, authorizing enslavement of the African people. In 1493, when Columbus returned, Pope Alexander I justified Christian European explorers' claims on land and waterways they allegedly discovered to promote Christian domination and superiority. If an explorer proclaimed to have discovered land in the name of a Christian European monarch, they planted a flag in its soil and reported his discovery to the European rulers and returned to occupy the land. It is now his, even if other people were there first. So what do we see here? These are likely pictures of smallpox or measles. We know that following Columbus's blunder, disease quickly spread throughout the indigenous people. The fact that my own tribe in Montana had never seen a European person until the early 1800s, but had already experienced a few waves of diseases, is a testament to extensive trade route throughout the Americas. We do not know exactly, but it is estimated that between 80 to 90% of the indigenous North and South American population was decimated by disease before European people or settlers came onto their lands. It is astounding. Gold was actually found in Georgia, of all places, in the early 1800s. And because gold was found there, the United States government at that time, hungry for these resources, the federal government began passing acts, which also shifted relationships with tribes. So one of the first acts that they passed was the 1830 Indian Removal Act. So in fact, Cherokee Nation was a very strong, powerful tribe, and they took the state of Georgia to court, to a Supreme Court, and they actually won. Cherokee Nation actually won their case that they did not have to be resettled and pushed off their ancestral lands of Georgia. But President Andrew Jackson never enforced this, even though the Cherokee Nation won their own case in the Supreme Court against Georgia. So this is the Trail of Tears, a depiction of the Trail of Tears. Now this happened between 1830 to 1850. Remember, this is the Cherokee, Choctaw, Chickasaw people who are being pushed from the southeast into Oklahoma. Now, some of these people traversed over 5,000 miles and across a number of states. There are about a total of today's present understanding of states, there are about 9 states involved where Native people were pushed onto the Oklahoma Territory. It is unknown how many deaths occurred because we were not keeping really great track, but the estimates are between 13 to 17,000 people, men, infants, women, children died during this period of time, this 20-year period of time. So this is just another depiction of some other routes. So it was the Cherokee, Cree, Chickasaw, Seminole, and Choctaw people who had been moved off their ancestral lands into the Oklahoma Indian Territory. I want you to look at this image, and I want you to think about food sources, because how do you motivate people to move away from their ancestral lands? One big way is to take away their food source, and that is in fact a policy that happened. So bison were a traditional major food source for many Native people. Look at this map. There were 2 different kinds of bison: the plains bison, which we know, it's on the nickel, and the wood bison, which was a bit smaller. Now, the wood bison was believed to be extinct up until about 15 years ago, where there was a small herd that was found in Canada, in a very remote area of Canada. Now they're trying to bring back the woodland bison, but up until about 15 years ago, we did not know that the woodland bison existed anymore. We thought it was extinct. In a span of 70 years, from 1830 to 1900, the bison in North America dropped from 40 million to 300 buffalo. Today's bison are descendants of the original 300 buffalo. What do you see in this image? These are thousands of buffalo skulls. Bison were directly targeted for sport, food, to sell their hides, to sell their tongues. But the dramatic shift in bison population is largely attributed to government policies aimed at eliminating this food source to weaken any uprisings, preventing tribes from unifying and living together in large numbers. A number of tribes had their own trail of tears, including mine. The Diné people were no different. In the summer and fall of 1863, Major General James Carleton ordered Christopher Kit Carson to enact the Scorched Earth Campaign, destroying homes, clean water sources, farmland, crops, and livestock in order to starve the Navajo Diné people, making it easier to remove them from their ancestral lands. Between 1864 and 1866, with few choices, thousands of native Navajo Diné people surrendered and were forced to march between 250 and 450 miles to the Bosque Redondo Reservation. While this was intended to be a reservation, it turned out more like an internment camp. It is unknown how many people actually died, but estimates are a few hundred. In 1887, the General Dawes Act was passed, and this was to facilitate assimilation. So basically, heads of households were given individual parcels of land to farm. After the government chopped up individual parcels of land and handed them out to heads of household, there was excess surplus land on these reservations. And the government then turned around and tried to sell this excess surplus of land on the reservation to non-native people. This is actually to show you the after effect of the Dawes Act. So this is a map of my reservation in Montana. So today the reservation is a patchwork quilt of land actually held by my tribe versus non-tribal settlers. The dark green is tribally trust-held land. So this is largely forested prairie land that is managed by the tribal government. The orange color are plots of land held in individual trust. So these are tribal members own their land. And these are usually 99-year leases. And it's intentionally made 99 years to help keep the land in Indian hands. The light yellow is fee land, or land that is no longer in trust, therefore no longer tribally held land. This is land that was largely sold to settlers by the US government or sold by Native people back in the 1850s. On my reservation, this fee land, this yellow land, is land largely held in towns around the lake and farming land. The purple area is the National Bison Range, which I'm happy to say is no longer owned and operated by the federal government, but is now in my tribe's hands. My great aunt was very instrumental in helping return the National Bison Range into our tribe's hands. So this next portion that I'm going to share with you it can be triggering. And I just want to warn everyone about that. One of the questions I often ask is, when was religious freedom founded in this country? Some might say in 1620, as the Mayflower landed, or with the First Amendment, but Native American people could not lawfully practice their traditional religions until 1978, about 45 years ago. On December 29th, 1890, a ghost dance, a spiritual ceremony of the Lakota people coming together, trying to make sense of their experiences and losses, threatened the US government. The US government sent cavalry to put an end to the ghost dance. About 300 men, women, and children were killed during this massacre. This is called the Wounded Knee Massacre. Again, this was in December. The ground was frozen, and the Native people lost over 300 people. The cavalry lost about 7 people. This is a rendition of that experience from Oscar Howe. So Oscar has a personal connection to this. His grandmother was a young child, and she recalls being shot in the hand during the Wounded Knee Massacre. Next, I'm going to talk about the Indian boarding school era. This is a picture of Haskell Indian Industrial School, and my great-grandfather attended Haskell Indian School. Not long after reservations were formed and the indigenous people forced onto them, boarding schools were created. These were oftentimes religious-based boarding schools that were federally funded to educate children. One of the oldest Indian boarding schools, built in 1879, was the Carlisle Indian Boarding School in Carlisle, Pennsylvania. Richard Henry Pratt, a Civil War veteran, founded this boarding school and he modeled it after the military system. He believed in corporal punishment and that it was necessary to kill the savage, strip him of his language, culture, and family, and reinforce this with corporal punishment in order to encourage children to rely upon themselves and not their collective community and family as they had been taught. Students were forced to cut their hair, change their names, stop speaking their native languages, convert to Christianity, and endure harsh discipline, including corporal punishment and solitary confinement for any infraction of these rules. This approach was ultimately used by hundreds of other Native American boarding schools, some operated by the government, and many more operated by churches. Carlisle was the model Indian boarding school for its time and became the template for federally funded Indian boarding schools, of which 26 more were modeled from and spread across the country. Over 10,000 Indian children were held hostage here, representing over 140 unique tribes with their own cultures and languages. It was customary for children to be sent far away from their homes to deter escaping. So children were often forcibly taken from their families as young as age 4 and imprisoned at these institutions until they turned 18 and 19, sometimes until their mid-20s. In the summer months, either children stayed at the boarding school or were hired out to surrounding families in the ongoing effort to detribalize the youth. This is just to show you that the General Henry Richard Pratt liked to use propaganda in terms of civilizing the savage. So he would often have these before and after pictures taken. And here you can see on the right-hand side, the savage Hopi Indians are transformed into model students is the propaganda. So you see them as they arrived to the Carlisle Indian boarding school. And then on the left, you can see them dressed in suits and their hair cut. This is Tom Torlino, a young Dene teen who had been captured and taken to Carlisle Indian boarding school in 1882 with other Dene kids. The side-by-side comparison, again, is of Tom's first day in 1882 and about 3 years later in 1885. 186 children's graves are at Carlisle Indian Boarding School, and survivors have shared their collective memories of murder and neglect. Children who tried to escape were hunted and sometimes killed. When reading historical documents, it's astounding as to the number of children who had died while out on an outing, and you can read the documentation supplied by General Pratt himself. September 30th is now recognized as the National Day of Remembrance for U.S. Indian boarding schools. Now, these are marked and unmarked graves on residential and day school boarding schools throughout Canada and the United States. So some would argue that as Indian boarding schools fell out of favor, placing Native children in adoption increasingly became the route for continued assimilation and cultural destruction. Remember, Indian identity is a complex and heatedly debated issue, both within tribes and on the state and federal levels. One area where Indian identity has life-changing implications is when we look at children being adopted. So there's 2015 data across the US found that Native children are overrepresented than any other ethnic identity within the foster care and adoption population. For every one white child, there are about 3 Native children in foster care. It is estimated that between 1/4 to about 1/3 of Native children were stolen from their families and tribes through this system. In 1924, Native people became citizens, but it was not until 1950s through the 1960s where this law was actually enforced. So Native people were not Native citizens until 1924. In 1934, the Indian Reorganization Act was passed, and this allowed a legal mechanism for returning surplus land back to tribe. One last method to deal with the Indian problem was to assimilate natives through a 1950s policy called the Indian Relocation Act. So this time, to assimilate natives, they looked to terminating reservations by encouraging whole families to move to cities. Over 200,000 natives were displaced or relocated into cities like New York City, Los Angeles, Denver, Chicago, Seattle, Oakland, San Francisco. This too proved disastrous because it left entire families stranded in cities without promised support and lack of support to return to their communities or completely dissolving their tribe. So today, 7 out of 10 Native people live in an urban area. And when we say urban, I mean by the US Census definition of 2,500. So there are many communities, towns that are population 2,500 that are definitely very rural, but in this sense, it's termed urban. In the 1970s, a woman walked in to a clinic asking for a womb transplant. She happened to be Native American and she happened to be seeing a female Native American doctor. The doctor then asked around and found that Native women had a particularly high rate of sterilization, and she wanted to know what was going on. So, through some negotiations and working, there was a Government Accountability Office report that was done in 1970s. And they found that for a 3-year period, 1973 to 1976, in about one quarter of um, the Indian Health Service sites. So there are 12 Indian Health Service sites. The investigation only looked at a quarter of them. They found that over 3,000 women had been sterilized. The youngest was about age 10. And it was known that through this investigation that most of the sterilizations against Native women happened to be improperly consented. And women shared stories about being coerced into being sterilized. So it's not clear why the investigation did not include all 12 sites, nor why it only included a span of 3 years. But experts hypothesize that at least 25% and as much as 40% of the American Indian childbearing population at this time had been sterilized. On the higher estimate, roughly 70,000 women may have been sterilized over this period. Comparatively, the rate of sterilization for white women was about 15%. Taking a woman's reproductive capability without consent is an egregious human rights violation. And when you target a specific population, it is genocide as defined by the World Health Organization. So now let's turn to reframing Native maternal child health outcomes. We know that today, Native women continue to die at higher rates. The rate is not necessarily decreasing, it is increasing over time. And there are wide gaps between American Indian and white maternal death rates. I want to point out that this recent report that was published did not use inclusive approaches to identify American Indian people. So for the most part, a lot of state and national reports, as you might remember, only include single race identity. And it's really, really important that we include multiple race identity and Hispanic ethnicity in addition to American Indian when we're trying to find the American Indian population, because we are a highly mixed population. We know that Native people, Native women, especially in rural areas, they travel at significantly farther than white women to access care. And in Montana, especially, Native women were about 20 times more likely to give birth at a hospital without any obstetric services, and they had less access to complex obstetrical care. Another obstacle definitely that Arizona has experienced, and Phoenix in particular, is the closure of PIMC and leaving a number of families feeling abandoned and without really great understanding for why the labor and delivery unit was closed. And this certainly could be impacting outcomes. We know that discrimination continues today, and this is evident in 2020 when a story broke about New Mexico, a hospital in New Mexico where they were enacting a secret policy that did not allow Native women to be roomed with their infant after birth. So let's just go back. If we look at all four women, intergenerationally, we're rooted in our history, living on our reservation, in a history steeped in violence, loss, grief, abuse, and fear. Aside from the sheer number of Indigenous people lost since contact to diseases and knowledge lost from those deaths, we need to consider targeted government policies that removed our people from ancestral lands, imprisoned them on reservations, forced them into boarding school assimilation, and carried out sterilization campaigns. We are very strong and resilient, and we have our cultural practices that have thrived and persist today. However, despite our resiliency and despite our cultural practices and despite being Native people living in community with one another, we still experience ongoing daily toxic stress in the form of high incarceration rates, racism on and off the reservation, living with the knowledge that women, girls, children may go missing and murdered any moment without thorough investigation, food and housing insecurity, and we can see how people might self medicate for their life circumstances, and how they may then be placed at risk for preterm birth, blood pressure issues, preeclampsia, infant deaths. So when we look at this soil, we can see that the soil was filled with these policies that were aimed to assimilate, to disenfranchise Native people. Some of these local solutions can be enacted on the regional and national level, but for the most part, let's start with local. So this slide, you can take a photo of it. It is just in a nutshell what can be done. So I'm going to go through these one by one. Better data. So we need better data in terms of our state and national reporting, and that can start with the hospital as well. So making sure that patients can mark more than one race and that Native American people can be counted, whether they have a single race, multiple race, or Hispanic ethnicity, will help improve data collection on our outcomes. So it's no longer acceptable to say that we are a small population, that we cannot be counted. So it starts with better surveys. So we can always advocate for better surveys in the hospital, at the state level, and on a national level. And this is just to show you that the CDC, when they were looking at maternal mortality review, and amongst about 36 states, when they reviewed the data and opened up, expanded their American Indian identification, they went from 9 cases to 17 cases when they were more inclusive. So better data sets is very important. Case reviews. We can always engage in 360 case reviews, looking at patient safety reviews, and include a multidisciplinary team of members onto the review. This is just to get a status update of how are we doing, especially with the American Indian population, especially with American Indian maternal child health population. Having people who represent the community on these reviews is also very important to having that community perspective. On the floor in the unit, across the providers and the nurses and the staff, you could host quarterly multidisciplinary health equity rounds. And so this is not just on Native American people, but in general, like health equity in general. So topics could address the forced sterilization among different groups of women. The federal policy was not just carried out on Native women, it was also carried out on Black women, Latino women, and it was carried out on disabled women. So, women in general and different groups of women had differential policies carried out with sterilization. Taking race and ethnicity out of the vaginal birth after cesarean calculator is an important discussion. If that is not something that the hospitals and providers are using. More recently, about the past 2 years, there's been a big movement to take out race out of a number of calculators because we know it's not biological race, it is the societal interactions of racism that are impacting health outcomes. Looking at the positive and negative social implications of long-acting reversible contraception among different groups of women. So this is another area to kind of review that while some providers may genuinely be really trying to help families think about their family planning or timing, it has been a practice. And if you look at how institutions are reimbursed for using these long-acting contraception methods, especially among certain populations, it is important to have an open dialogue or discussion. These are just potential ideas to talk about at a health equity rounds. And of course, having providers, staff, and everyone who takes care of patients from the front desk to taking calls to a provider, The implicit bias training. Now, the implicit bias training is not meant to stand alone on its own 2 feet because there should always be reflection involved and guided facilitation of this work because it is not just a one and done. What are some other things that can be done? So, screening. So it is really important to screen at every single visit, perinatal visit, whether it's pregnancy, preterm, prenatal, in the hospital when they're there for labor and delivery or postpartum or even a well baby checkup, that people are screened for violence, for substance use, depression, anxiety. Very important. But when you do this, it is also equally, if not more important, to have care, referrals to care for people who are testing or who are screening positive because there have been cases depending on which state people are practicing in and the local laws that if someone comes in and has a positive toxicology screen that automatically child protective services or law enforcement can be notified. And that, again, can put a barrier and mistrust, preventing people from accessing care. So it is important not to place the burden on her shoulders in terms of she's a bad mother because she's testing positive on this or that. It's really important to understand the social determinants of health, her her history, um, her experiences to really understand why self medication might be happening or why someone might be in an abusive relationship. So support for the dyad and family is very important. Equally important, building trust with Native community. So this is where it might be the most challenging because it's going to take intensive care of a relationship and sustaining a relationship and visibility with local partners in your community. So, again, if you're trying to overcome distrust and fear in the healthcare setting, then partnering with your Native community partners will be very helpful. Also, employing trauma informed care and culturally safe care as ways of interacting with patients will help versus um, maybe like a cultural there's a debate about whether people can be culturally competent versus culturally humility or culturally safe. And increasingly, people are understanding that you cannot be competent in someone else's cultural life and lived experiences, but you can have humility, but you can also have understanding where you can try to make things safe, which is why I like the intersection of culturally safe care and trauma informed care because they both work well with one another. So, for example, always asking permission to do an exam, always having a second person to witness sensitive exams in the office or in the hospital is important in trauma informed care. Culturally safe care may be that reviewing hospital policies in order to um, reviewing hospital policies in order to allow certain ceremonial practices to take place. So building trust is going to take time. Here is just one example. I am not sure how you say the Siowat Pachli collective, but thinking about your community partners, the other birth workers there, like the doulas, lactation consultants, and building a bridge and communicating with these different organizations could only help the patient's experience and outcomes. Again, here are some other ideas. I know that Marina Farrell, she is the founder and owner of the Phoenix Midwife and Parteres de Maíz, as well as Melissa Brown and Candace Newman. These are people who are in the birth world in Phoenix that you can get a hold of and try to reach out and see if you can build connections and relationships. The Intertribal Council of Arizona, also located just down the road in Phoenix, is also a great resource where trying to build partnerships would be very valuable in improving relationships and outcomes. A few more options. You can invest and recruit a workforce that is culturally and linguistically congruent in order to give the community more options for care and service delivery. You can also think about investing in more in the birth workers, the diversity of birth workers. We have lactation consultants and perinatal nurses and community home health nurses. You have midwives, you have nurse midwives and certified professional midwives or certified midwives. You have people in the home birth world. You have like doulas. There are a number of people on the birth worker team, social workers, mental health, that could be pulled in to give diversity surrounding providing wraparound services for the Native family. Finally, a larger, wider community action that can be taken is that we all pay attention, listen to the Hear Her campaign. So this is more of a calling upon our nation. The CDC has rolled out the Hear Her campaign, which I understand at the meeting in September, people were being introduced to. I highly recommend going online and looking at reviewing some of the vignettes that people have shared about their experience. The Hear Her campaign, through stories, is trying to help providers, patients' families, and then I would say the larger community. Even if you don't know anyone who's pregnant, someone at a grocery store or at a gas station, it should be in their knowledge system of understanding, recognizing when a pregnant person is having a headache or faints or is not feeling well, that that person is connected to services immediately. So I see the Hear Her campaign calling upon our nation as a whole to take care of that person. And that is how I believe that we can be in more service with one another and be in community with one another and not be separate. So again, this goes back to the power of listening. I believe that the power of listening will help us in the end be better clinicians and better service providers, whether you're in the healthcare system as a leader, manager, nurse manager, or provider, or someone at the front desk. Thank you very much. It has been my pleasure to record this presentation for you, and I will also be including a PDF list of resources of just extra reading, browsing on YouTube or watching videos to help kind of flesh out some of this historical piece.